the voice. And so let's begin. We all know the sickle cell disease is the most common genetic disorder among African Americans, and pathology is the single base pair mutation in beta globin chains and resulting into abnormal polymerization upon deoxygenation RBC, which takes characteristic sickle shape and which leads to severely shorten the red cell lifespan and severe anemia. So, you know, just one second. Yeah. So average life expectancy 42 years old for males and 48 in females. 1 in 600 African American birth result in sickle cell disease, and almost around 2,000 new birth takes care annually. One of the predominant countries, Nigeria, where almost like 150,000 born with sickle cell disease annually. So this is a worldwide problem, not African American. In India also, we do have a lot many sickle belt in the southern part of the world. So, long-term organ damage in sickle cell disease are common, particularly neurological, which everybody finds. Almost 11% will have a stroke before age of 18. One third will develop silent stroke by age of 15, and the TCD will be productive to find out the neurological problem, and most of the people will have cognitive dysfunction. Pulmonary issues are also common, particularly acute chest syndrome, which in long term leads to pulmonary arterial hypertension, which is 40% by age of 40 and leads to right heart failure. Renal insufficiency, very high risk of infections because of autosplectomy, and recurrent vaso-occlusive crisis leads to pain crisis, bone infarct, and iron overload because of chronic transfusion. So if you look at what are the current treatment option in sickle cell disease, it's a supportive care management, the prophylactic antibiotics, pain medication, blood transfusion, and then hydroxyurea, which increases the hemoglobin F. And the many clinical trials showed hydroxyurea does benefit into number of crises goes down and sometimes stroke. But only the hematopoietic stem cell transplant is a curative treatment for sickle cell disease. There are so many newer drugs which are approved. Hydroxyurea came first in 1998. In 2017, which is a long gap of almost 20 years, L-glutamine came, then trijanilubab in 2019, and then voxelotor and gene therapy was approved in 2023. So these are the pharmacological agent which can be treatment for sickle cell disease. But what is available today with the everyone is hematopoietic stem cell transplant, and that's a allo transplant is only sole curative treatment, and best supportive care fails to improve the quality of life as sickle cell anemia remain associated with the high risk of morbidity and early death. And only a small fraction of eligible patients receive HSCT due to lack of suitable donor, lack of information, and limited understanding of the transplant. So HCT can be considered for selective group of patients because sickle cell disease is a heterogeneous. All sickle cell disease, sometimes those who are silent, not having a repeated pain crisis or only one crisis in 1 year, so only episodically, but those who get recurrent crises and will come again, what are the indications? So for selected group of patients, that transplant is curative, and in the long run, it's not just economically but also substantially improve the quality of life. HCT also does encompass a high risk of early and late onset complications. So you have a matched sibling donor, you go ahead with the transplant. If you don't have matched sibling donor, you look for unrelated donor transplant, or which could be either mismatched unrelated donor, cord blood transplant, or haploidentical transplant. So always the best result are matched sibling donor transplant. So these are the current indication for HSCT in patient with severe sickle cell disease, which is unresponsive to hydroxyurea therapy. So please look at carefully, read each and every, and for all the physician or GPs or pediatrician, what is important, you know, these are the guidelines. These are not absolutely, Bible. So a matched sibling donor transplant, wherever you have overt stroke or CNS event lasting more than 24 hours, import neuropsychological function with the abnormal cerebral MRI and angiography, elevated TCD, which is not responsive to hydroxyurea or chronic blood transfusion therapy, recurrent acute chest syndrome despite hydroxyurea therapy, recurrent severe pain episode, red cell elimination, pulmonary arterial hypertension, recurrent priapism, sickle nephropathy, bone or joint involvement, sickle retinopathy, and stage 1 or 2 sickle cell disease. Matched sibling donor transplant for everyone should be considered, where you have to look at partially mismatch related or haploidentical donor. So, a recurrent stroke despite adequate chronic blood transfusion, severe sickle cell disease symptoms, unresponsive to hydroxytherapy, these should be considered. And today, this was the when the sickle cell disease guideline was set up in the early 2010 and 2015. So, but now the haplotransplant results are so better, almost equal to matched sibling donor transplant. So, the current these recommendation or suggestion that you have to consider depending on the patient who is severe sickle cell disease. If somebody is resource constant, recurrent hospitalization, recurrent infection, AVN, they should be considered for transplant, whether irrespective of whatever the donor. So again, in the different format, though, who are the candidate for transplant? So match sibling donor or alternative donor transplant. And these are the ASH recommendation for HSCT again, and with the level of the evidence, so R1 to R8. So if you look at what are the pros and cons of the transplant of the different approach, if you look at the matched sibling donor transplant, you can actually achieve a disease-free survival of 85%, OS of 97%, long-term follow-up, almost like in these patients around 15 years. So most of the patient do get a cure. There's a small risk of graft rejection in the 7 to 10% and transplant related mortality around 10%. In the haploidentical setting, the survival is not there, but there was more rejection earlier when they tried with non-myelability. And in our experience, now people are using a different platform. So rejection rate with this currently almost equal to जो match sibling donor transplant around 5% to 10%. So you can have a different approach. And this is the what outcome one we can get with the transplant. So majority of patients who cross the barrier of first 3 to 6 months, they remain cured forever. Haplotransplant has been tried and we have looked at in our population, our colleague. So the long-term outcome, if you look at the haplotransplant, is the one of my colleague working with me earlier, so almost around 90%. So overall survival and event survival of haplotransplant, if you look at in the current data set, is almost near to matched sibling donor transplant, which is around 80 to 90%. So comparing with the standard of care of the SCD for transplant, so HCT is potentially one-time curative therapy. HCT for sickle cell is again evolving newer conditioning regime, alternative donor, and method of cell harvesting because growth factor, bone marrow, or everything is difficult in sickle cell disease. They can actually create a crisis. And now these days, a Plarixifer, which is available for stem cell mobilization, is very a good alternative for mobilization. So more and more safe regime are coming in the world for sickle cell disease. Success rate is improving and survival rate both children and adult with SCD receiving DMRD and supportive therapy also improving. So short and long term risk of transplant should be considered in comparison to currently approved therapy. And one has to look at what are the risk of SCT related complication with the every age if you cross. So in matched sibling donor and alternative donor transplant in early age, the viral infection particularly are problem, risk of veno-occlusive disease and SOS. But if you look at when you do transplant in the elderly patients, the age of recipient increases, the transplant related mortality, particularly systemic vasculopathy, is already there. So, neurotoxicity, PRES, VOD, graft versus host disease, and most of these patients are already alloimmunization that leads to delayed immune reconstitution and graft rejection. And there is very high transplant related mortality. So, early age of the transplant, you have better outcome, less complication. But one has to realize that the time of the transplant we cannot control. The whenever patient comes to us with the severe symptoms, we have to offer that time whatever the best available treatment. So if you look at what are the recommendations for neurological injury, for HCT, so HLA match related HSCT is suggested over standard of care in patients with sickle cell disease who have experienced an overt stroke or abnormal TCD. The, and when considering transplant for neurological injury, children younger than age 16 who received mass sibling donor transplant have a better outcome than those who are older than 16. So timing of transplant, age of the recipient, because if the recurrent stroke had led to already cognitive dysfunction, the paralysis or the focal neurological deficit, that cannot be recovered. So you can cure sickle cell disease, but you cannot, you know, recover the neurological injury, whatever had happened. So neurological injury caused by overstroke and the sickling crisis is a major complication of SCD. Almost around 24% of the sickle cell disease patients could be affected by strokes. Chronic transfusion and other supportive therapy are useful to prevent stroke, but they are not curative. So long-term, the CRCT is associated with the risk of the alloimmunization and the transfusion overload. And that's why the effort to prevent primary or secondary stroke focus on curative option with the transplant. And these are the summary of the post-HSCT neurological outcome. And most of the patient do well. But again, I'm saying some of the patient, because of the infarcted area is there in the brain that lead to recurrent stroke, hemorrhage, or other complication, particularly seizure. So one has to take patient upfront for transplant whenever you have a single episode of neurological, the complication. Same thing with severe symptoms, sickle cell disease, whatever recommendation, again, those patients who have recurrent painful episode of crisis, particularly acute chest syndrome, they should be considered for transplant. And these patients should be offered for, even that there is lack of mass sibling donor transplant, you can have an alternative donor transplant. And you can, if you look at the outcome, these are early and presented in 2019, and early transplant, if you look at the data, is now reaching better with the newer conditioning. So almost reaching to more than 80% of the transplant outcome is whether mass sibling donor transplant or haploidentical transplant, if you look at the second graph. So today's date, the donor type doesn't matter actually. So a patient who are the reported outcome of pain intensity and pain impact improved post HSCT in the subset of patient, those who have intermittent pain pre HSCT, and some patient will continue to experience pain post HSCT and be not able to chronic pain. So chronic pain, that wherever you have a,
Sorry to interrupt. There's a red line coming on the
I
slides.
don't know how from where it coming. Somebody else was scribbling. I don't know.
Okay, should not
So
comment. No, then we can continue with this. It's okay.
it's not from my side. Somebody else was doing. I don't know how it happens.
Okay, no problem, sir. We can continue.
So again, I'm saying the severe sickle cell disease transplant should be offered, but sometimes the chronic pain persists despite transplant, because wherever the neurological injury is already there, you need a nerve. So one has to keep in mind that the chronic pain is sometimes problem post transplant also. Word about conditioning regime. So people have used different conditioning for different age group. So in the current world, hematopoietic comorbidity index, depending on age, comorbidity, you have to decide the conditioning. So standard conditioning, when we started transplant in early 2000, then BUSI ATG was standard conditioning, which leads to higher graft failure the disease-free survival. But now these days, the IV busulfan is there, and the different modification of the again the ATG leads to better graft survival, the graft failure, and this is all simultaneously better graft selection because of HLA typing, high resolution. So the graft failure gone down. The OS survival is almost more than 90% of patients in the myeloablative transplant done with the HLA matched sibling donor transplant. A non-myeloablative for elderly, the compromised patient. So you can use fludarabine base along with ATG. Again, the disease-free survival, OS survival, if you look at, almost more than 90%. But in the non-myeloablative and reduced intensity, there are mixed chimeras. So if you look at the disease-free survival is ranging from 80 to 90%. So, what is recommended that you should use a TBI-based chemotherapy for when you're conditioning with non-myeloablative. Otherwise, massive link donor transplant is the best, which is a best outcome when you use for younger patient. Adult patient, again, the sickle cell disease can be in 30s presenting the bad complication, AV and priapism. So a non-myeloablative conditioning or reconditioning is preferred over mass sibling donor transplant. So so again, the age, if you do transplant for less than 15 or 13 years, the age, the myeloablative should be considered because you have to kill the whatever the affected marrow, and those patients have best outcome with the full myeloablative conditioning for young patient. But patient who are older patient, they have pulmonary arterial hypertension, sickle retinopathy, nephropathy, neuropathy. They have other comorbidity, and that's why that those patients are not chosen for myeloablative, and you look for non-myeloablative or reconditioning. So again, this is a proposed the algorithm for allotransplant in the. So what is the most common? The people, and currently what we follow, the fludarabine based conditioning with the ATG is the commonest, and this is haplo platform where you have some thiotepa thumb radiation to prevent rejection. So when people have looked at the review comparing allotransplant to gene therapy in sickle cell disease, and I'll just touch upon few things where gene therapy is gonna just come and what will be the place of the transplant. And what they found, if you look at in the 56 studies representing almost 1200 patients, met inclusion criteria of the study. Length of follow-up was almost like 3881 and 57 patients a year for SCT and gene therapy. Overall quality of evidence was low with no RCT was identified. 2-year overall survival for SCT patient was 91%. Mortality was around 2.5% for the gene therapy. Acute chest syndrome, vaso-occlusive episode were reduced post SCT and gene therapy. Meta-analysis was not possible due to lack of comparator. And what they conclude is the reporting of the sickle cell disease related complication and patient reported important outcome is lacking for both studies. We advocate for standardized reporting to better outcome. So gene therapy will not have any the major advantage over the transplant. And the penny has dropped for sickle cell disease. This was a beautiful article. So by Elian Gluckman, who did the cord blood transplant. So what she said, the role of HLA identical sibling transplant in sickle cell disease with 5-year OS of more than 95% when performed at early age and using a bone marrow as the stem cell source of the patient. And what is the said that pediatric hemato-oncologists often encounter reluctance on the part of hematologists to refer their patient with sickle cell disease for transplant, with an overall survival of 95% among young patients with SCD using mass sibling donor. There is no need to perform controlled clinical trial for comparing chronic transplant, hydroxyurea and SCT. Planning controlled prospective clinical trial to explore the best conditioning regime, either myeloablative or eric transplant in the setting of match unrelated donor transplant is next challenge. So what actually it means that most of the patient the need transplant, and you can one thing outcome is almost near to 100%. So this should be referred early. And what this was few months back I analyzed what we have done. We are now close to 1500 1600 transplant, and the almost two-thirds are match allogeneic transplant. One almost half patients are match sibling donor transplant, and we have done the quite haplo transplant, almost around 270 plus, and these are the different the out profile. And what we have done the sickle cell disease 65 transplant, including the mass sibling for 29, haplo 5 35, mud for 1, and we had the overall survival of 83%. And mind it, this the western data what we get to the India, the most of the patients come in the comorbid condition, late referral, alloimmunization, and if you look at almost more than 50% are haploidentical transplant. So outcome is always almost equal to the Western world. And I'll end here with acknowledging my friend and department colleague, especially Dr. Divya Doval is my colleague working from last 10 years, patient, my lab physician, the nurses, and other support, and including administrative and data manager. Thank you so much for your patience listening, and we'll be happy to take the question and interact with you people.
Okay, sir, one question, like you mentioned in your talk also that when patients come to India, so many times the referrals are late, like they are already adults or close to adults and have already developed comorbidities, etc. Uh, Also, they face challenges, sir, like real sibling may or may not be 100% match. And very often we encounter a case that either a parent, if not a sickler, or a related family. So can you explain more on that, sir? Because this is the question we face very commonly from our doctor partners. They want to understand the uh, just more
So,
little clarity behind it, sir.
so can I, Varun, if the respected doctor permit, can I just brief what is the basic for transplant?
Yes, sir. Please, that will be helpful, sir.
So I have, I will take 5 minutes. Do you know what a general physician should know about transplant? Because I have spoken only a focus about transplant, why transplant in sickle cell disease, and what are the outcome. Because the Africa, practically every second or third person will be affected by sickle cell disease, whether it's a carrier or disease. So that was the reason. But I will just, take you what is the basic about transplant, what a physician should know about transplant. Okay, Varun, I'll probably not take the more than 5 minutes.
No, sure. Please, sir. This will be really helpful. Super. This will be super helpful.
So, uh, all the doctors, am I, understandable, or should I speak slow?
It's a little better if little bit slow. We all have different countries, different accents. So,
So, okay, a bone marrow transplant when we do, we historically used to take bone marrow from the posterior iliac spine and infusing in the recipient intravenously. So donor bone marrow cell repopulating in the recipient. That was the concept. Okay, and objective of transplant, we want to deliver high dose chemotherapy to destroy leukemias, particular tumor. It provides a source of salvage ablated marrow, particularly like after chemotherapy or aplastic anemia. It stabilizes organ graft tolerance to prevent rejection, and it provides immune effector cell to mediate graft versus tumor activity. And the birth of transplant are all started after the Second World War. And this gentleman, Dr. Donald Thomas, who got a Nobel Prize in 1990 in medicine for this discovery of transplant. For physician, this definition are multiple, so you can divide depending on source of the stem cell. So when you collect stem cell from the bone marrow, you call bone marrow transplant. You collect from the peripheral blood, you call peripheral blood transplant, or cord blood transplant if you're using cord blood. When you choose donor, so if you're related donor, so either match related donor transplant or match sibling or haploidentical donor transplant, and unrelated donor transplant through various registries. A word about auto transplant. Sometimes we do transplant from the stem cell from the self. So this is a misnomer term. where actually we use high dose chemotherapy, and the autologous stem cell we use for rescue to overcome the ablated marrow. It have advantage because it has very less transplant related mortality. There's no rejection, no graft versus host disease, and there is no immunosuppression. But it does have a less cure. There is no graft versus tumor, and there's a potential for tumor contamination. And this is a scheme where first we collect stem cell and then give chemotherapy and reinfuse stem cell after that. And you can cure these so many diseases by autologous transplant. So major indication are multiple myeloma, non-Hodgkin lymphoma, and Hodgkin lymphoma. Allo transplant means where I was talking sickle cell disease. What it requires a suitably HLA identical donor. So we always earlier talked about full match sibling donor transplant and haploidentical. It have advantage. It can have a graft versus tumor effect. The immunological which lead to cure. So where the donor immune response against malignant cell, but it does have the disadvantage because of graft versus host disease. There is more infection and the more risk of rejection. But these days the infection rate come down because better antibiotics, antifungal treatment, better immunosuppression, and the graft rejection are very less because high resolution HLA typing available for to so you can actually identify who is the best donor. For requirement for transplant, what we need these common like class 1 and 3 allele A, B, D are minimum. But for when you're looking haplo and unrelated, 10 antigen A, B, C, DRB1 and DQB1 is required. And now more and more typing you do to better identify donor. Chances of matching is that if one sibling is there, 25% chance of full match, and when its family size increases, the chances to find a donor may be better for homogeneous racial group, wherever particularly consanguineous marriages are there. And wherever the now the donor is not there, this landmark paper had put everything aside. The haploidentical donor transplant became standard of care when you use post-transplant cyclophosphamide. And number of haplo transplant, if you look at worldwide, number is after 2010, it's exponentially increasing. So outcome is almost same, and people are doing not only for malignant disease, non-malignant disease also haploidentical transplant. I used two more terms: myeloablative transplant, which is full intensity, young patient, less than 15 years old, you can do myeloablative transplant. And reduced intensity and non-myeloablative, people are not fit or having comorbidity. So every patient have chance to get cure, whatever way of transplant is being done. As I said, the allo transplant, you need a donor. You collect donor from either marrow or peripheral blood and infuse intravenously. And you can cure like these so many malignant disorder, particularly AML, MDS. There's no cure. Transplant can cure. And if you move non-malignant disorder, and particularly thalassemia, sickle cell disease, Fanconi syndrome. So these diseases are only cured by allo transplant. So, and this is the way of doing allo transplant. You collect stem cell, harvest. In allo transplant, you use fresh, autologous, you cryopreserve, and so on. So I'll stop here. This was like, what is transplant for physician? So I'll
Sir,
hold here and we'll take question.
okay, sir, there was this, yeah, this slide, sir, like the pre-BMT phase and BMT day and post-BMT, because when the doctors, they
Can I
recommend,
go? Can I can continue. So
yeah,
how
yeah,
the transplant is done? There is a three phases of transplant. The trans pre-BMT, which is I'll come. It's a conditioning. BMT there is just a stem cell infusion, and post-BMT is where you wait for engraftment. And every patient before transplant donor recipient they get a detailed workup, and these are steps. Every transplant your patient comes, they will get some secure venous access, they get conditioning regime, which is means preparation. You have to kill the recipient marrow, you have to create a space for donor cell to populate. So that is conditioning regime. Then every transplant, in allo transplant, they get a graft versus host disease prophylaxis. You have to prevent fighting between T cell of the donor and recipient, which are the cause of the rejection also. You infuse stem cell, wait for engraftment, means donor cell repopulate in the recipient. You have to monitor them for close monitoring for first 30 days to 100 days and long term follow for almost 5 years for late complication. Conditioning regime, there are drugs from and radiation. So intensity increases, the toxicity also increases. So non-myeloablative and rig transplant for less fit patient. Myeloablative again for the fit patient. Every patient before transplant they get GVHD prophylaxis, which goes for almost like 1 year, 6 months to 1 year immunosuppression to and contrary to liver and kidney transplant, they require lifelong immunosuppression. Our patient they get the immunosuppression for 6 months to 1 year maximum. There is risk of infection in transplant, and every phase, whether it's neutropenic, immunodeficiency, which till you are continuing immunosuppression, they are immunodeficient, which are almost like 1 year. So most of the patient after 1 year, they get the immune reconstitution back, they get revaccination, and they are free from the risk of infection. A word about GVHD, which can be acute and chronic graft versus host disease. This is only a problem of the major problem of the transplant, which is because this can ruin the quality of life. But again, I would touch upon one slide here. If you doing transplant for malignancy, like twin transplant, there is no GVHD, but risk of relapse is very high. So in malignancy, you need GVHD because it govern graft versus malignancy effect. And those patients who have both acute and chronic GVHD, which is controlled, the relapse rate is less than 10%. So GVHD is a boon for the malignancy transplant. Again, few complications, the VOD, hemorrhagic cystitis, and then you have to look for any complication for close monitoring up to 100 days and then monitoring up to 4 to 5 years. Long-term complication has to be kept, particularly risk of infection. Infertility is very common in post-transplant. So wherever possible, we collect stem cell, semen or ovum before transplant. That is a major issue coming from the African people. Everybody wants to have the family. Everybody has to have their own children. So we have to collect the sperm, but younger patient, less than 10 years, we can't collect semen. We can't preserve ovary. So these patients are really, really problem for future, particularly infertility. So I'll and every patient they comes to a physician back with some chart we give for post transplant vaccination, which should be started after 1 year, and no even sibling should get live vaccine, particularly live polio vaccine, if they are the patient had transplant and other sibling is getting OPV, they secrete polio virus and they can get paralysis. So they will come with the chart for revaccination. So I'll stop here, Varun, and we'll be happy to take a question.
Yeah, so we have a few questions. But I think you may have answered through these slides. So there is a question from Dr. Ivan. He's from Uganda. This question is, help us with the pathology of stem cell and what are the effects of the transplant. So I recall in one consultation, a patient asked you that how generally and in a very general you answered that their health would be like compared to with respect to sickle cell like as good as a donor. So but I think if you can explain this so that Dr. Ivan gets more clarity.
So what is the question?
So pathology of the stem cell.
Pathology of stem. The stem cell is a pathology of sickle cell disease.
No, he has written help us with the pathology of this stem cell.
The
So
stem
maybe
cell, there is no pathology. Stem cell is a cell which is mother cell, which is in every human being, every mammals, which produce blood. So we are talking about hematopoietic stem cell. So there are in our body there is pluripotent cell which goes to hematopoietic stem cell, mesenchymal stem cell, endodermal. So many type of. So we our patient have a defect in the hematopoietic stem cell.
Okay.
Okay. So sickle cell disease, as I said, it defect in the single gene. Okay. This is what the sickle cell disease. So the single gene defect, single base pair in the beta hemoglobin chain. So here there is hematopoietic stem cell is defect. So and we need to replace with the healthy stem cells.
Okay. And so his another question is the effects of the transplant. Like you explained in detail, even the monitoring, but maybe I'm trying to guess. Dr. Ivan, can you clarify your question with respect to effects? Because I recall, sir, one patient consultation with you which I attended, and their question was after transplant, how is my life going to be? Then you
So
said
again,
similar to
so
donor. Yeah.
true. So I'm coming. So what are the effect of the transplant? Basically, a complications. So what complication can happen after transplant? As I said, 70% nothing, 30% will have a graft versus host disease. There are some acute complications. So let's go by acute phase. There will be complication. There will be neutropenic. Neutropenia can lead to sepsis, infection. We have to treat. In the post infusion, there will be risk of mucositis, that mouth ulceration that leads to pain, the vomiting, diarrhea. So and some they will be treated with narcotic analgesic. Then two more complications. I said hemorrhagic cystitis means the people passing blood in urine because of the either radiation or cyclophosphamide, hydrocyclophosphamide they receive during transplant conditioning. So that leads to the damage to the urinary bladder epithelia, and the treatment is hydration and prevention. And once the recovery is there, thrombocytopenia recover, neutropenia, majority of patients do recover. Another complication is veno-occlusive disease in the liver because the chronic hepatopathy, sickle cell disease, iron overload, blood transfusion lead to some hepatitis B, C infection. So all leads to the the thrombosis in the liver vein. So that can be tender, painful, the liver, fluid collection, ascites, jaundice. We have to prevent that. But what is the two important complication is that one is acute graft versus host disease and second is chronic graft versus host disease because all the quality goes bad with the chronic graft versus host disease where you have a dry eyes, dry skin, dry mouth, lung problem, which sickler have even predisposed because they have a recurrent sickle cell crisis lead to sometimes lung fibrosis, pulmonary arterial hypertension. So hypoxia is part of the sickle. So we have to do transplant, keeping in mind that we have to reverse these. So chronic graft-versus-host disease does impair the quality of life. The another complication, as I said, infertility. Then, if the patient needs immunosuppression with the steroid, they can lead to cataract, avascular necrosis. With sickler, they are anyway getting AVN. So we have to keep in mind.
Okay, sir, when you talk infertility, when you're discussing infertility as a side effect of bone marrow transplant treatment, so does it mean the inability to reproduce, or does it mean sexual dysfunction also?
So infertility means inability to reproduce. So sexual the doesn't get affected. So coitus, sexual, the social life never get affected after transplant. It's only ovarian failure or testicular failure means the sperm genesis, spermatogenesis, and ovulation that is affected.
So we have a question from Dr. Wasim. Dr. Wasim is from Chad. His question is, apart from transplantation in symptomatic sickle cell patients, is there no antigen therapy for asymptomatic patients to prevent homozygous transmission?
No. So it's a gene defect. So there are two things. One is sickle cell carrier and one is sickle cell disease patients. Sickle cell disease means both parents were carrier and that lead to a sickle cell disease. And sickle cell carrier is only one gene affected, so they can pass on sickle cell disease to the progeny if their partner is sickle cell carrier again. Other than gene therapy, there is nothing, no treatment for sickle cell disease, a non-transplant, no cure. For asymptomatic patient, nothing is required because they are as good as carrier. So many sickler, they are mild sickler, they never complete, they reach to adulthood and they live normal life like you and me. So if there's no phenotypic expression of the genotypic disorder of sickle, no treatment is warranted. Because every treatment carry a risk of morbidity and mortality.
Okay. So, sir, there is another question. The doctor name is not displayed, only device name. So his question is, what is the age for patients that can do this bone marrow transplant? Although you discussed that younger the age, better outcomes, but is there a upper age cutoff, like after which you will not consider that benefits are not gonna outweigh the risks?
So we advocate, I always advise a youngest should be more than 2 years of the age because doing transplant very early, 6 months, 1 year, only one episode of crisis, and the children can't take the proper immunosuppression. It's very difficult. Sometimes on emergency you do for leukemia, but sickle cell disease, thalassemia, after 2 years of age, one should offer transplant. Upper age is not, you know as a human, where every patient have right to live, whatever result percentage is 70%, 80%, for that individual patient that doesn't matter. So that discussion, the decision to go for transplant is depending on the patient and family. Again, if you say there is a bad patient, quality of life is bad, even chances of, like in leukemia we do 30% cure rate, you do transplant because there's no other treatment. So if the sickling recurrent crisis, life is miserable, so one has to do transplant at every age, and you have to choose conditioning from the non-myelability to reduce intensity to, so you have to design the transplant, the treatment according to the patient profile.
Okay. Uh,
Only patient which I differ. So who are the actual patient are not at all candidate for allo transplant. So those patients who have a organ failure like liver failure, kidney failure, somebody who is paralysis on bedridden, so stroke is so bad, then at least those, or lung failure, where you have a diffuse diffusion capacity of lung is less than 70%, or you have a cardiac compromise, cardiac failure, these organ system failure, these patients are not a candidate for transplant. Otherwise, age has nothing to do with the whether transplant can be done or not. I have done probably the oldest sickle is around 36, 37-year old.
okay. Sir, another question around this, because like as doctors or as a practitioner, you understand, and in mathematics, you understand probability, like head or tail is like 50, but which toss will get what? So if you can explain, so like you explained to one patient that when we talk about these percentages of success, 70%, 8%, 80%, every family wants to know which bracket their child would be in. So you had beautifully explained to a family, but if you can
So,
explain to doctors.
Varun, I speak to every doctor, and I always give my example that we all are in 1%. The statistics is for doctor when I do transplant for 100 patients, and then I draw a percentage. If I do transplant for 5 patients, and I cannot draw a percentage. So I tell the patient every patient is in 1%. For patient you are in 1%. Yes, I can tell that when we do patient like you 100 patient, these are the outcome. Whether you fall into that 1%, you still fall in 1%. Even I say 99% success rate, but if you land up in 1%, you are zero. And whatever I say is 30% outcome and you fall into 30, you are cured. So percentage is statistician fool to the patient, blah blah blah.
Okay. Hey, Dr. Ivan clarified that he wanted, and you had already explained that post-transplant complications. Now we have a question from Dr. Innocent Zili. He's from Kenya. What are the measures in place to reduce graft versus host disease in allogenic transplant where donor cells attack the body?
Yes. So as I said, the every patient wherever allo transplant is done, there is risk to graft versus host disease. Even full match sibling, except the identical twin, every patient there is a risk. So we give every patient immunosuppression because no transplant is done without immunosuppression to prevent graft versus host disease, to prevent rejection. So now these days, the better drugs coming for treatment, which are can be used for prophylaxis also, like ruxolitinib for chronic, acute and chronic graft versus host disease. So there are better drugs, ATG, if you use in during transplant, the risk of graft versus host disease is minimum, but cannot be zero. So all depend on the what is the conditioning, what is immunosuppression, what is the stem cell source. The blood peripheral blood stem cell have more risk of GVHD than compared to marrow. Then if doctor in the fear of graft rejection give more cells, peripheral blood, higher stem cell dose leads to more chronic GVHD. So it has multiple factor. A doctor, a transplant physician who is taking care of your patient should be wise enough to do a right transplant, not any transplant. And sometimes people who are resource constrained in the many small center, they are only relying on the cost. They remove the ATG from the transplant, which is the really expensive medicine. So to reduce the cost of transplant, if you remove ATG in conditioning, your risk of GVHD is more. So many times transplant can be done better, the result can be improved more, but it does carry the risk of more cost. So it comes with the little extra cost. But if you do transplant for elderly, the not child, so you have to do safe transplant. And when you do safe transplant, it will be little extra cost, and the cheap transplant should never be done. So if I would always say you send to X doctor, he said I can do in half the cost of the transplant, it means he's doing a wrong. So please be stay away from the only looking at the cost of transplant. Bone marrow transplant is a medical procedure, not a surgical. So it's not like liver and kidney, you cut and paste. This is here all the game is that medicine, medicine, and medicine. If you use better medicine, the more medicine it will cost.
Sir, I mean, you touched upon a very practical point and gave clarity around how doctors or patients should evaluate options.
I'm saying ATG. If you remove ATG, which is like almost like a 1/10 the cost of the whole transplant. Okay, if you remove that, and then your outcome will be bad. You have more chance of GVHD. If you are lucky, you have avoided, but otherwise you'll end up in a problem.
Okay. So now, just sir, this perspective, I mean, bone marrow transplant is expensive treatment because of so many medicines and such a long procedure involved. But compared to Europe and India, I'm compared to Europe and US. In India, it is still very cost effective. So if you can talk about a little bit about the cost implication to the patient, so that I mean the ranges, and I know it may vary, as you said, that many times you don't discover till the transplant is in the process that how much medication or how much care the patient is going to need, but still, so the cost implication
So
and
cost is a dynamic one. Second is cost is depending on the country where you practice, and that cost goes to GDP of country. So if the average cost of any treatment or any where you even stay in US is expensive, then it will be expensive multiplied by whatever factor you do compared to India. So don't go on to just Europe is more expensive or America more expensive. It's their GDP. But this is important point where African traveler to the US or to the India. So I always believe they should travel to the best center in the India where they can get the medical treatment without any compromise equally same. Medicine is the same, only cost of the human being, the hospital bed charges. So compared to America and the Europe, the hospital charges are less in the Asia. So that's where you save the cost. Medicine sometimes the cost more or less same. The good medicine costs at the most of the places same, other than the whatever the local tax is. But the supportive care medicine, supportive care, so many things in the healthcare, consumable, they are cheaper here. So if you look at, we do almost like a one fifth of the cost of the America
Okay.
or UK.
Uh,
Maybe if you look at America, probably it goes one tenth. But this is for African who are traveling. But this cost don't compare the American versus Indian cost.
Okay. So there are a few questions from Dr. Dima from Ghana. And first, his compliment, thanks for the elaborate presentation. And this is a timely reminder of how to save our humanity in critical times, giving hope. His questions are, what is the racial survival rate after transplant according to current statistics and research? So is race a factor in success of transplant? Because you only mentioned the full match and half match only. I mean, you didn't mention, you did talk about racial
So
signification
I
in
tell you,
research.
the race is actually doesn't affect the outcome. I said that sickle cell disease, like African sickle cell, they're more severely sickler compared to, if you look at Indian sickler, they're not that the severe symptoms. So that is the presentation, but outcome is the same. Like leukemia sitting in Africa versus leukemia sitting in the India. Transplant outcome is mainly affected with is the patient factor and donor factor. Patient factor is disease, stage, and the comorbidity of the patient. Donor factor is full match, half match, or mismatch. That's all. So where your outcome is different is that if you choose right, and then treatment factor. If you choose right conditioning, right immunosuppression, right supportive care, outcome across the globe will be similar. Whether you do transplant in America or you do in Tokyo or you do in India.
So here's another question, sir, related to nutrition. I mean, are there any clinical nutritional consideration before and after transplant?
No, we encourage nutrition. Na?
Yes.
So, so we encourage patient whatever they like, they eat. Good nutrition, whatever they're liking, there is no prohibition. Only some people say that don't eat street food, but good patient, good families, they don't believe in eating food from the street and corner. So any hygienic food you eat in family, good nutrition, good protein amount is good for good transplant outcome. And for that is for ordinary every healthy human being.
Okay. And again, sir, he says, because his name is Dima, so he says your name sounds, Dharma sounds very similar to him.
So we were
Uh,
lost brother.
yeah, Dr. Dima, Dharma means righteousness. I mean, there's a Hindi Sanskrit word. Its meaning is righteousness.
No,
So,
Dr. Dima and Dharma, we were brother in the past life.
yeah, and Dr. Dharma also shares his name with a very famous Bollywood star who recently passed away. So it's so the name literally means righteousness, so the correct path. And sir, you talked about long-term follow-up. So, like in Jivo model, where we have a patient's local physician who is initiating the referral, who is being kept in the loop during the treatment with the critical information. Once after the monitoring part in India is done, they go back. So, for how long? Like you mentioned that they have to be revaccinated. You issue instruction card which they have to follow. But for how long should the patient keep coming back to them? Like, and at
So
what
actually,
frequency?
the a very important point, Varun. So I am doing the transplant for international patients from last 15, 17 years. So since I came back from the Canada and started North India of the first transplant program. And if you say my 70, those out of, if I take 100 international patients, 60 or 70, I am directly connected with the referring doctor. I always send them with the referral note what to do and what is not to do, how to monitor, how frequently, and try to be connected with it. So a success of transplant is not what I do here for first 30 days or 100 days in India. Success of the transplant is with you people, sir. How you monitor whatever you do, we do here, and if tomorrow they go and they stop the immunosuppression, they reject and die, or they'll end up in chronic GVHD. So it's a better to speak to the treating doctor or referral physician who is taking care after returning back home at least once a month for 1 year till they are off immunosuppression.
Okay, so they are not on immunosuppressants for life. They are just for a limited period only.
Only, I just said, the bone marrow transplant patient, depending on whether you do leukemia or sickle cell disease, they are immunosuppressed for 6 months to 1 year, majority of the patient, until somebody is developing very bad chronic GVHD and on long-term immunosuppression. But majority, almost like 90% patient will be off immunosuppression by end of the year, and then they get revaccination. So we want to connect to the doctor at least once a month for 1 year till they are off immunosuppression. That will lead to a better outcome. We can actually together we can improve 20 to 30% more outcome compared to those who lost to follow up.
Okay. Okay, no, no, that's a very important point, Dr. Dharma, that you raise. And as when we talk to with our doctors, and we all
Sorry,
discuss
really,
one thing that
Preet, I need to go.
somebody is saying something. Yes, please repeat your question. Hello, I think they've gone quiet.
Varun, want I we give when they go our email, our phone number. They can communicate on email or WhatsApp. In case of emergency, so they should communicate because just doing a procedure is not enough for right outcome. So 30 days or 100 days has no meaning.
No, no, the right, sir. Sir, basically, what we are trying to fix here is like currently the cross-border healthcare system, it's broken. There's hardly a structured dialogue between doctors across the borders, and many patients they get lost to follow-up. So what we realize and what we're trying to do is that healthcare is a care continuum. Like there are multiple steps before travel, after travel, and if structured in a structured way, the doctor has access to you, the local doctor has access to you who has made the referral, then together you can form a better plan, which the patient can follow up. So one more question, and we face this very often. In some countries, even the HLA typing test is not available. In fact, this is a recent request from a patient that now sometimes we have a patient traveling from the same city. So how do we collect samples? How does our physician, GO doctor, collect samples? What precaution to take? How it should be transported so that it can reach a good center like yours, and the testing can be done? Because
I will, circulate maybe tomorrow if you can remind me from my lab doctor that, the prerequisite for HLA sample. So it can come to India, the blood sample. In each and every country there, I think now network of the most of the laboratories are there, the Metropolis and other, or in Kenya and Lancet is there, in Ghana, Uganda and these places, Nigeria, not many
In
centers are there.
DRC, in DRC, it's not there, sir. Like we have somebody requesting that how we can send samples of
So
sibling.
I will give you full information, friend, from the lab doctor. So the what temperature, how many hours, how many ml of sample, blood sample, or buccal swab.
Okay, that will be helpful, sir, because like we have to find ways of
Absolutely,
overcoming the challenges, and somebody traveling can bring the samples here. So I don't
absolutely.
see any more questions, but I want, sir, like the larger message is we are here to, by building these connections between specialists across the borders, we are here to figure out a way how we can benefit more of humanity. So again, the questions are the right selection of the patient. Not everybody is going to benefit, as you said. If the symptoms are mild or asymptomatic, they don't need it, and the age factor, etc. Sir, if we can circulate, we have prepared a referral document guideline, but if we can review it, because it becomes very important for the doctor practicing there to
Sure.
identify and counsel the right candidate, because as you said, not everybody is the right fit.
Yeah.
So,
Only, I didn't say negative things. In transplant, again, I did speak, but not highlighted. There's a risk to the life, and we have to reduce the risk of life by right treatment, because otherwise every transplant, whether full match, half match, mismatch, whatever you do in medical procedure, there is a risk to the life, and in particular transplant, 10 to 20% risk to there. We have to cut down, we have to minimize by close follow-up, long-term follow-up, reporting, seeking help from each other, and do best possible for the patient's outcome.
and also, sir, like I always give comfort to doctor partners that many times a patient may not have resources, etc. But if you have any doubt about managing the case, you can write a doctor's note. We'll share it with the right specialist, and whatever guidance is possible, they will provide. But if it comes from you, that means more rather than it coming from me. That
Sure.
when they have the right patient and they need, okay, maybe if Dr. Dharma can have a look at my note and point me in the right direction. So that
No,
comfort.
no, we are two-way discussion, because whatever concern is that we have to discuss and address.
Yeah, because sir, in Africa also, African countries, they are developing, we are developing a lot of similar challenges to India. Like New Delhi and Gurgaon is not India. India lies beyond. So we have similar socioeconomic challenges and similar problems. So the comfort that I give them is that we all understand.
Sure.
Yeah. Thank you, sir. Thanks a lot for
Have
your.
a great day to everybody, and thank you, Varun and Atul. So, thank you.
Thank you,
Thank you
sir.
so much, sir. Thank you so much.
Thanks a lot for your time, taking time out on a Sunday and agreeing to conduct this master class, sir. Hopefully, sometime in future, we can have around sickle cell or stem cell transplant another session with the African doctors sometime in future. Thanks a
Sure.
lot for your time. If anybody has any question around sickle cell, bone marrow, please write a note. We will share it with Dr. Dharma, and as soon as possible, considering the busy schedule, we'll get you a response. Thank you, sir.
Good day to everyone, and happy Sunday.
Happy Sunday, sir. Thank you.